Yes, all of this. Welcome everyone to Breakout Session 3C, the impact of system affiliation on critical access hospital financial indicators. And just a reminder that the session is being recorded. If you have any technical difficulties, you can use the chat feature and I'll assist you with those now that we're all here. Deep breath. We do encourage questions and comments for the presenter. So you can type the questions in the chat or verbally ask a question by clicking the chat feature on the bottom of the Zoom platform. In the reactions, you can raise your hand. And we will have Terry get started with the introductions, and then we'll turn it over to Kathleen.
Okay, these are the learning objectives. So upon conclusion of the session, participants will be able to discuss differences among system affiliation variables from the popular data sets, understand the effect of system affiliation on hospital financial indicators. And so let me read the bio of our speaker. By the way, Kathleen, I do not want to mispronounce your name. I probably should have asked you before. How do you pronounce your name?
It's Knocke.
Knocke, thank you.
Yes.
So Kathleen Knocke is a PhD candidate at the Department of Health Policy and Management at the University of North Carolina Gillings School of Global Public Health. She works as a graduate research assistant at the North Carolina Rural Health Research Program on various projects related to rural health, hospital finance, hospital service provision, and program evaluation. Her dissertation focuses on rural hospital-based maternity unit closures and maternal morbidity in North Carolina. So thank you for being here, Kathleen, and I'll turn things over to you.
Awesome, thank you for that introduction. Let me just, can I share my screen?
Yes, yep, but if you have any difficulties, I can share it for you. But okay. There, yep, we see
Everyone's seeing
it.
Perfect.
Yes, thank you, Kathleen.
Okay, so as we just were introduced, my name is Kathleen Knocke, and I am here on behalf of the North Carolina part of the Flex monitoring team. And our project this year has been on looking at system affiliation and then looking at that impact on the critical access financial indicators. So here's just a quick overview of our team. I'm sure many of you are familiar with us, but we're Kristen Ryder, George Pink, Mark Holmes, and then our new additions and specific to this project are Laura and Anne, who did a lot of the programming work and a lot of the hand searching that I'll talk about. So we're really thankful for them. We already went over the learning objectives, but the presentation will be in two parts. The first part will be on the system affiliation variables and what we found trying to work on this project. And then we'll actually have some results about system affiliation and how that relates to the financial indicators. So we'll start with the system affiliation part. There's sort of two definitions. There's three definitions. And on this slide, there's two of them. And from the HCRIS, which is the Healthcare Cost Report Information System, I'll be going by HCRIS for this presentation. We pulled line 140 from the worksheet S2, which is not super relevant, but it specifically asks about home office costs. And so that is actually going to be a measure of ownership. And so whenever we talk about the HCRIS system affiliation variable, what we're really talking about is ownership. And in the American Hospital Association annual survey, there is system affiliation information that is on the membership file from the hospital association side. And that one includes more information. Hold on, it's hiding. It's 2 or more hospitals owned, leased, or sponsored or contract managed by a central organization. So beyond ownership, it adds in this extra piece of contract management. The last data set we looked at was the ARC compendium for US health systems. And this is a data source that sort of combines AHA data and also QBO1P data. And they have a definition that includes one hospital and at least one group of physicians that are connected through common ownership or joint management. So again, they're looking at ownership and something else. We in North Carolina looked at each of these data sources, and since we're super familiar with the hospitals, we actually know which are in system and which are out of system. And according to our understanding of the hospitals for the year 2018, this is how the breakout across the data sources looks. So 77% of the time, the ARC data source either said, yes, they're in a system, or no, they're in a system, and that was a correct indicator. And for AHA, that's 86.5, and for HCRIS, that's 94.2%. Here's sort of a visual of the different types of arrangements we found whenever we sort of did this exercise and going through each hospitals. And HCRIS really only captured the sort of formal ownership system affiliation relationships. And then the AHA data set had these sort of formal management agreement data set relationships, and the AHRQ had sort of the broadest definition where they included alliances and affiliates. And so this is a table I'll probably make reference to of being really careful what you're trying to measure and which data source you're going to use. We then sort of applied this to all rural hospitals. And in the data set, there were 2,193 total rural hospitals. 844 of those did not have any system affiliation, and all of the sources agreed on that. And then there were 563 that had discrepancies, meaning that all 3 of the sources did not agree that they were in a system. And so you can sort of see in the middle that there were 785 where they did agree. ARC by itself definitely had the most hospitals included in their system affiliation definition, followed by AHA and HCRIS, and that sort of follows what we found in the North Carolina set. So in the system affiliation variable that we're using in the sort of analysis in the next part, we narrowed it down to critical access hospitals. Of the 1,360, there were 1,126 that matched. So we sort of, if both of them agreed that they were in a system between HCRIS and AHA, we sort of took that as that was true. And then for those that didn't match, we actually hand searched the internet and used our sort of merger database and anything we could get our hands on to try and figure out if it wasn't a system, if it wasn't a system, and then report why. So for 25 of those hospitals, there's inconsistent naming. So like they didn't match because they said that they were named something else or they were part of this other group, but we did find that they were in a system, just weren't quite sure about what the name of that was. There's a merger reporting lag that we found that where depending on the timing of when each of the data sources collected the data, a hospital could have merged in that year afterwards, or I guess like unmerged or gotten out of a system in that time period. And so there was sort of a disagreement about internally whether or not it was in a system, but it was sort of an artificial disagreement. And then there were 59 that we found that were in no system affiliation, and then the rest of the 116 we found were system affiliated. Sort of the key takeaways from this part of the presentation is that there's more than one way to define system affiliation. Really think about the type of relationship you're wanting to measure. So if in our case, we wanted to know true ownership because we were looking at financial relationships and wanted to understand the financial relationship between the hospital and its owner or its larger system. It's really difficult because these are sort of binary to narrow in on what other relationship other than ownership is happening underneath. We had some information because we actually knew the North Carolina hospitals, but at a national level, that would be really difficult to do. And the final point is that timing really, really matters. Be really careful about when you ask someone was being ask about system affiliation when it was collected, when you're reporting it, because this information seems to be outdated really, really quickly. So moving on to our actual project for the year, looking at the impact of the system affiliation variable on financial indicators. So for a little bit of background on this topic, there's been an increase in rural hospital mergers and acquisitions. REAPRE found that there was a 6.2% increase between 2007 and 2016. And there's a bunch of perceived benefits in the literature about becoming affiliated with the system. And these include access to technology, staff recruitment and retention, expanding healthcare and operational services, group purchasing, and reduced cost of capital. And to this point, we are not aware of any studies that have looked at the impact of system affiliation on financial performance of critical access hospitals. So for our purposes in this study, our system definition is ownership of a critical access hospital by a health system, excluding managed contracts and other arrangements between hospitals and health systems. The outcomes in the models that we ran are financial indicators. And so for those that have who have used CAHMPAS before, probably really familiar with these. They're not different. And there's a primer link in the slides that you'll have access to if you don't know what I'm talking about. But they include financial indicators that give us insight on financial performance and how they are benchmarked against other hospitals and their peer groups, their service lines, and hospital operations. We did a cross-sectional study of critical access hospitals using the year 2018, and we did linear regressions controlling for other hospital characteristics. These are also their peer groups. So net patient revenue, whether or not they were government owned, whether or not they operated a long-term care unit, and whether or not they operated a rural health clinic. And then so in our system affiliation process that I described above, we found that 43% of the critical access hospitals were affiliated with the system in our sample. And we sort of searched, I touched on this earlier, but we searched through information that we had gotten from the University of Minnesota Flex team, hospital websites, really anything we could get our hands on. I'm going to leave this up for a second so people can look through. The bolded financial indicators are ones that we found significant results for. And so you can sort of see overall, there's a lot of stars, a lot of bold. I don't think it's a surprise to many people that there was a significant relationship between hospital affiliation, system affiliation for critical access hospitals and impacts on financial indicators. Here's a sort of summary slide that interprets that information for everyone who doesn't want to read a bunch of numbers. But we saw profitability go up. We saw the use of equity financing go up. We saw the ability to cover debt service payments go up. revenues from outpatient go up, patient deductions go up, and average salary and uncompensated care go up. We also saw that days net in gross accounts receivable, meaning that so they got through accounts receivable faster. So we saw that sort of indicator go down. We saw debt financing, age of plant, Medicare outpatient cost to charge, and FTEs per adjusted occupied bed all decrease. So for those on this call, overall, we found system affiliation to be associated with higher financial performance. And this is particularly important for interpreting, comparing, and evaluating critical access hospital performance. For example, if you're comparing critical access financial indicators in the online flex monitoring campus system. I think that we're working on how to incorporate this information going forward, but that's all to be determined. And there is my contact information and information about the flex monitoring team.
Thank you, Kathleen. There was one comment from Nick.
Yeah.
He said he wouldn't have predicted that much variance, and that was interesting. I think that was related to the system.
The Venn diagram, I'm sure. Yeah. Yeah, we found, we were also quite surprised, but in the literature, there's not a lot of guidance on the differences between these system affiliation variables and sort of what they're actually measuring. So we're working on a paper that should be coming out pretty soon that sort of gives guidance on, if you're looking at this research question, we would recommend using this data source for these reasons, and going through and trying to make it a little bit more practical for people.
Okay. So there's another question for Nick Galvez or Caroline. What about nonprofit compared to for-profit health systems?
Yes, let me pull up the brief for that.
And while she's doing it, Kathleen's slides are available in the attendee hub. If you click on this session and scroll past the bio. So if you want to dig into the financial numbers, all the slides are there.
Yeah, so I'm looking at it all right now, and a lot of the results for each of the hospital characteristics, so the net patient revenue, the government ownership, long-term care unit, had really similar results to the system affiliation variable. I can probably share this really quick.
Is this brief on the FMT website, Kathleen? Because I can find
Not
that
yet.
link. Okay.
Not yet.
Okay. So we're getting a peek.
Yeah. So this is sort of the proxy for nonprofit and the regressions, but you sort of see it aligns pretty heavily with how system affiliation was treated in the regression. So we don't have any information on the size of system. In the analysis that we ran, we only used a binary variable of whether or not we were in a system. We found it really difficult to even sort of sort through that variable on itself. And then trying to sort of go further down from that proved to be even more difficult. So I think as we start to get more data and this becomes more of a important topic, hopefully we get there where we can start to look at, do you own 1 or 50 hospitals or different relationships like that.
Kathleen, in your definition of system, did you take into account the more horizontal type of networks like the rural Wisconsin co-op, for example, or ICANN, the Western Healthcare Alliance, et cetera? Were those considered systems, or because there wasn't that central body, they were excluded?
So in the analysis that we ran, they would have been excluded, simply because there's a lot of missingness in the AHA data, and for the ARC data, our sample of North Carolina made us sort of wary of using it because it was so inclusive. But I think using the different variables from the different data sources, you might get a little bit different results. But since we're specifically looking at the financial relationships, we chose the cost report financial sort of arrangement.
There's another question here. Was any information available on the number of critical access hospitals in each system or other rural hospitals and nursing homes?
So I'm not sure I totally understand that question. We just looked at whether or not, like, as a binary variable. So were you in a system or were you not in a system?
Okay.
Yeah.
Not how big a system, and they and they owned.
Are we allowed to talk?
Yes.
Lisa.
Yes. Go ahead, Lisa.
Sorry, hi. So thanks so much for the presentation. I was, one of the things that I think we're interested in seeing here in our state, which is Pennsylvania, is for a larger health system that is interested in acquiring a critical access hospital, is there a predictor is having a critical access hospital, especially one that has a nursing home or a small rural hospital that also has a nursing home affiliated with it, any predictor of whether or not a larger health system will find them to be attractive?
That's a very interesting question. In this analysis, I don't have a lot of insight into predictors, just sort of at a cross section. Nothing's time series or over time or in the future. How does this impact future financial performance? Part of that would definitely be because a lot of the data sources are sort of cross-sectional, or we can't really track them over time.
So that might be one of those questions that if you're writing a journal article, it's always good to say, these might be some of the things we could do some future research on, right?
Definitely, yeah.
So, all right, thank you so much.
Yeah, I'm going around about this, the message that you said, sort of a takeaway that as we're comparing data, factoring in whether or not they're system affiliated or not. In other words, sort of giving a +1, so to speak, to an independent for the same metric amount and a -1 for a system affiliated one. But it would be super valuable if you all, since you went metric by metric, could sort of give us, and I know that not every state is going to be the same, as Lisa's pointed out, even within the systems, they're not going to be the same side by side, but some sense of how you would suggest ballparking that adjustment. I know it probably makes researchers nervous to ballpark things, but nonetheless, just having some sense of how to adjust that metric by metric would be useful for us.
Okay, that's great feedback that I can take back to the North Carolina team. Thank you.
Thank you.
Following up on Lisa's question, whether or not a hospital has a nursing home, what its financial assets are, et cetera. One of the things that I've been seeing is a lot of the attractiveness for a bigger system, including a hospital, has to do with how they've kind of prepared for value in population health. Both Sally and I have done a lot of work with the Mayo Clinic, for example, and they're very choosy in terms of who they want to affiliate with. And a lot of times for what I think what we could see, it's more than just the financial situation in the hospital. It's, is this hospital working with its local community? Is it doing care coordination? Can it show us value, you know, in that larger context that we've talked a lot about in this, this conference? And I'm thinking that the more progressive big healthcare systems are kind of moving in that direction.
Yeah, I think that again, I mean, that we keep giving you future hypotheses to look at, Kathleen, is the as Terry's saying, that to look at the impact of that ownership on their preparation or their stability to move into value and population health, especially since many value models from HHS are introducing risk. And to take on risk, they need to have a stable or healthy bottom line. And then
I'm writing all these down.
Okay, there's and Jack, do you want? Jack had a comment on the risk of stating the obvious. System affiliation will not necessarily impact financial and operational indicators unless the CAH is owned outright.
Which is exactly why we came to the HCRIS conclusion of true ownership versus the sort of expanded definition of affiliates and management contracts.
Okay, so you looked at true ownership. Okay.
Right.
Okay, and then Nick from Alabama noted this ideal data source direction will be very helpful to us in the future. Cost system dynamics vary so greatly. This subset would definitely aid in benchmarking accuracy. Cost pooling and resource constraints alone are huge influences on them.
And I think, so this is all really, really fresh research, like done in the last couple of weeks. So I do think there is an intention to incorporate this into CAHMPAS and into, I don't think we decided that we could do peer groups because it's like 5 factorial number of peer groups and they became way too small, but being able to sort of incorporate this and how you are looking at your critical access hospitals internally. Maybe as like a checkbox or dichotomous or something like that, but we're going to try and make this usable information.
Okay, so it wouldn't only be the type of ownership of government or nonprofit, but they could click on system?
Right.
Okay, great. Okay. Do we have other questions or comments? You can unmute yourself.
Great job, Kathleen. I think we have a lot more research ideas for future FMT products, but it's been great to hear this really direct feedback from our Flex programs, as well as what other information would be really helpful. So any other ideas, I encourage you all to throw them out there so that we can hear them.
You know, it would be really interesting to do this sort of analysis on our networks. Because we put an enormous amount of money, I think, well put into healthcare networks, and I'm wondering what has been the financial outcomes on those networks as well. So I just think a companion piece to look at rural health networks, particularly the ones that were a little more advanced, not the initial ones, but some of the more mature networks out there.
And Kathleen, the brief will be posted and of course shared with the Flex programs, and we'll share it in Rural Route too when that is available.
Definitely. And we also have a paper coming out that gives more detail about how to use system affiliation variables sort of moving forward for research questions that we can share.
Great, wonderful. Okay. Well, if there are any other questions, just a reminder, we have a break. So we're reconvening at 2:40 Central Time, 3:40 Eastern for the final keynote session. Joe Tai of Values Coach, Building a Culture of Ownership in a Post-Pandemic World. And to attend the session, you'll return to the attendee hub, but no, you can, if you have to step away or lose connection, you can always go back and join live. And the then following the keynote, we'll have closing from FORHP. Yeah.
Hey,
Go ahead,
Sally,
Jack.
before we get off, I'm picking up on Terry's comment about networks. So there were 500 and some, Kathleen, of your 500 and some hospitals that are owned by systems. What would be really interesting is how many of those hospitals are in one of the networks that Terry talked about. And what would be, and then the question would be, what's the benefit of a owned hospital from membership in a network? Just
Yeah, that's
a
a
network guy, I'm throwing that out there.
good point, Jack, because we know in a lot of these networks, rural, just looking at Wisconsin, the rural Wisconsin co-op, great many of their members are in systems, and that might be the Wisconsin one may be the most advanced network that I'm aware of in terms of what they do. But I think the ability to to integrate the efforts of the network with the systems themselves has been a true accomplishment. So good suggestion.
Nice job, Kathleen. Thank you.
Yeah, thanks, Kathleen.
I just wanted to add.
Oh, I'm sorry, go ahead, John.
Oh, sorry. I just wanted to add that I think Nick makes an excellent point. Reflecting on this, it really matters how the system is treating the particular hospital. They might be using that critical access hospital as a loss leader, as a way to kind of balance their books against more profitable hospitals. Or they could be working with them, sort of fully investing in them as a full-fledged partner. So yeah, this is good information, and at the same time, it's an important reminder, I think, to not just add that +1 without investigating a little bit deeper as to the dynamics of each particular hospital.
And so, John, you really read my mind. That's very much what I was thinking about. And one of the challenges that we have in our state is exactly what John is talking about. Understanding the rationale and the motivation behind the system in acquiring the hospital. And what we try sometimes well and sometimes unsuccessfully to do is to make the case for having the critical access hospital not be just a feeder into the larger health system, but that this is really an investment in the community, and that these rural communities are just as important as the metropolitan areas, and that investing in that hospital actually brings greater rewards than just being a source of referral up to the larger health system. But John would say it much better than me.
I sincerely doubt that, but I do like this idea of trying to come up with some, and I guess we have them in patient satisfaction scores, but sort of an add-on to that, because if I'm a CFO at a large system, I could certainly look just at the numbers for that hospital, but we've been told over and over from a variety of ways that a hospital's long-term strength and sustainability comes from more of the esoteric things about the quality of care. And so there's got to be some tension there, I would imagine, between how one could look from states away at a small hospital purely on financials, or how they could look at them on how to invest in them for long-term financials.
Absolutely. Thank you both for those comments. And
So Kathleen, I think
observations.
we've mapped out your research agenda for the next 5 years.
I know, I'm like, well, if we can measure it, we can look at it.
Right.
Yeah, but I think it just, I mean, that you shared, you know, from looking at the data, that 43% are affiliated. I mean, it's like, wow, it's sizable, because we're hearing, you know, more and more from states that to manage a flex program when you have significant systems, it takes a different approach, you know, and certainly the type of ownership and even some of the dynamics that Lisa and John raised to impact how are they working on quality and EMS and population health beyond the finances.
Right.
Yeah. Great.
And there's things that we've noticed in our contracts. We'll often get a system like a Mayo, for example, since you mentioned that one, that will turn down, say, SHIP funds or some other sort of opportunities that an independent wouldn't. They would look at that amount of money and say, well, we'll figure out a way to do this. But a system will just sort of broad stroke and stop 5 to 8 hospitals in our state from taking part in this. It's a very different dynamic when you're dealing with administrators on how they're going to respond to opportunities, how they're going to communicate with those trying to do our sort of work.
Yep, absolutely. Great. Well, thanks everyone for being patient to get into our room. You got one last comment, Terry?
No, I just wanted to say goodbye to everybody. Thanks. Thanks for all the comments. It was great to have the interaction among the folks in the audience.
Great. Okay, we'll take a little stretch break and we'll see you all back at the attendee hub.
Thank you.
Thank you, Kathleen.